When you think about the presentation of any lung cancer, including small cell carcinoma, you need to put them in three compartments, three boxes. A set of presentation occurs due to the local invasion or the involvement of the lung. This is the box number one. The box number two is their widespread metastasis. The metastasis could be due to bone, to the central nervous system, to the liver, and other places. And the third box should be for the paraneoplastic syndromes. Paraneoplastic syndromes are usually when they release certain antibodies or certain hormone. For example, small cell carcinoma, they release the causes paraneoplastic syndrome by three A's. A for ACTH, A for antidiuretic hormone, and another A for antibodies. For example, anti-HU antibodies or antibodies against voltage-gated calcium channel, which causes Lambert-Eaton myasthenic syndrome. So when we think about the manifestation of the clinical manifestation of the lung cancer, you always need to think that a set of presentation involving lung, the airways, so they can present with cough, they can present with the features of hemoptysis, respiratory distress, dyspnea. Another set of presentation would be due to their widespread metastasis. For example, it can present with a seizure, it can present with a headache because it's frequently lung cancer, particularly the small cell carcinoma, the metastasizes to the central nervous system. And also another set of symptoms would be paraneoplastic syndrome. So now the topic of this InstaLecture number 105 is particularly we'll be focusing on small cell carcinoma of the lung, which is the most lethal, the most aggressive, and the deadliest among all lung cancers. It has a rapid doubling time, and usually it metastasizes at a very early stage. And that's why it carries a very poor prognosis, and it's the most aggressive form of the lung cancer. And by the way, lung cancer is the most common cause of cancer-related mortality worldwide. Since 1953, it is the most common cause of the cancer-related mortality in the males, and 1987 is the most common cancer-related mortality in the females. And out of all the type of lung cancers, particularly the adenocarcinoma, squamous cell carcinoma, large cell, or the small cell, the most aggressive form of the lung cancer is this one, which I'm discussing right now. That is the small cell carcinoma of the lung. Now, how small are they actually, the small cell carcinoma? The small cell carcinoma of the lung, they are usually, there is a parameter there that they should be less than 3 times the diameter of the normal resting lymphocyte. And usually they are 2 times of the size of a lymphocyte. So when you see in the biopsy, you see these cells are usually blue cells, blue tumor cells, which are looking quite like lymphocytes. And it was also previously called oat cell carcinoma because their appearance oats in this. Now, coming back to the key features of the small cell carcinoma, I think you have seen this thing that all the time, conventionally, we divide the lung cancer into small cell carcinoma and non-small cell carcinoma. So these are fundamental concepts that I feel you need to understand here, that why this kind of classification is created for the practical purpose. Why not we classify it as adenocarcinoma versus non-adenocarcinoma, squamous cell carcinoma versus non-squamous cell carcinoma? Why we think in this way? Small cell carcinoma versus non-small cell carcinoma. The typical reason for this is that this is a cancer which has a very rapid doubling time. That means it doubles, it's very aggressive, it doubles in a very less span of time. And secondly, that this tumor at the presentation is widely metastatic at the time presentation. So surgical resection is not the way to treat or manage the small cell carcinoma. On the other side, the non-small cell carcinoma, adenosquamous cell carcinoma, they can be treated surgically. Surgical resection is possible because their metastasis is not so common. But on the other side, small cell carcinoma, around 70% cases, they are metastatic at the time of presentation. Metastasis could be to the central nervous system, bone marrow, liver, and adrenals. These are the places where the metastasis typically occurs. Now, coming back to the other key features of the small cell carcinoma, it's always typically associated with smoking, and it's virtually never seen in non-smoker. Only up to 1% cases they are seen in non-smoker. So usually you'd be getting a patient who has a history of heavy smoking with a high number of back years of smoking history. They are presenting with the small cell carcinoma. And as often I mentioned, typically they would be often presenting with some kind of metastasis at the time. As they usually involve the central areas because they are located usually centrally, So CARP would be a presenting feature. And depending on the site of metastasis, if it is the metastasis is to the brain, they can present with seizure, they can present with some kind of neurological features, which would be associated presentation. If there is a presentation in the bone, metastasis of the bone, they can present with the bone pain. So depending on the organ of the metastasis, the presentation would vary depending on which part they have metastasized. And obviously, as I mentioned, one key feature of the presentation would be paraneoplastic syndrome. So some small cell carcinoma patient may present with the features of Cushing syndrome. For example, a 59-year-old male chronic smoker, he can certainly present that there is some alteration in the mood. He's feeling low. He's having some flares of acne, and since college time, he has no episodes of acne. There is some kind of moon physis development. He's developing high blood pressure. He is certainly noted. So all that purple stria. So these kind of features of Cushing syndrome could be the first presentation in a patient of small cell carcinoma of the lung, because they release ACTH and adrenocorticotropic hormone by the tumor cells. And as I mentioned, when you think about paraneoplastic syndrome, think about 3 A's in the small cell carcinoma. One A is ACTH, another A is ADH, antidiuretic hormone. So small cell carcinoma can also release antidiuretic hormone, and antidiuretic hormone can cause SIADH, syndrome of inappropriate antidiuretic hormone, which can present with hyponatremia, dilution of hyponatremia, and it can present with a confusion like feature is patients. Another set of feature important presentation is Lambert-Eaton myasthenic syndrome, which is a myasthenia gravis-like feature, where the patient usually presents with a proximal muscle weakness. And this is a problem of the neuromuscular junction, but the problem of the presynaptic membrane neuromuscular junction, in contrast with myasthenia gravis, which is a problem of postsynaptic membrane. And in this condition, Lambert-Eaton myasthenic syndrome, LAMBRT, Lambert-Eaton, EATON, myasthenic syndrome. It's usually called LEMS, LEMS. The particular problem is this, that the acetylcholine cannot be released from the presynaptic terminal, because there is autoantibodies which are produced against the voltage-gated calcium channels in the presynaptic membrane. And this is usually seen in small cell carcinoma of the lung, and around 3% cases of the small cell carcinoma lung could be associated with LEMS. And many times, LEMS could be present even before the small cell carcinoma of the lungs arrive. So this could be an early harbinger for the patient of the small cell carcinoma of the lung. And it could be associated with other antibodies also, like anti-HU antibodies, which usually associated with encephalomyelitis in the patient. And by the way, the most common cancer which is associated with neurological paraneoplastic syndrome is lung carcinoma. And another important concept is that the most common cancer, lung cancer, which is associated with paraneoplastic syndrome and all this ectopic hormone secretion, is also small cell carcinoma of the lung. Because the small cell carcinoma of the lung, they are usually thought to be a neuroendocrine origin. They are usually thought to be originated from Pulchitsky cells. And as they are a neuroendocrine origin, neuroendocrine carcinoma, so that's why they usually, what is the property of endocrine organs? They release a lot of hormones. So that's why this cancer, this tumor also releases a lot of hormones, as I mentioned, like ACTH, ADH, and they can also secrete other things. Particularly the antibodies which I mentioned, which would be crucial for them. And that's why the neurological manifestation is also occurring, because it's a neuroendocrine origin cancer. Now coming to the diagnosis of this small cell carcinoma of the lung is obviously biopsy-wise, but it's a histological, histopathological. And the histopathological, you see certain characteristic feature. Certain characteristic feature is they usually have the cell would have very scant cytoplasm. That means they have a very high nucleocytoplasmic ratio. I would like to explain it in the whiteboard. So let me go to the whiteboard and explain the biopsy features which you need to understand here. So in small cell carcinoma, what we usually see that normally what we see that a cell usually has nucleus, this is N, and they have cytoplasm, the rest portion. And usually the nucleocytoplasmic ratio in normal cell is 1:4 to 1:6. 1:4 to 1:6. This is the normal ratio. But what happens in the small cell carcinoma of the lung? This is a normal situation I'm talking. But in a small cell carcinoma, what you see that the cell is almost entirely made of nucleus. This is entirely nucleus, and a little bit amount of cytoplasm could be there. This means little scant, sparse amount of cytoplasm is present. So this means that nucleocytoplasmic ratio is definitely altered. In a normal cell, there's a less amount of nucleus and more amount of cytoplasm. But in this cell, what you are getting? Mostly the cell is made with nucleus. And the nucleus is hyperchromatic. And in the nucleus of the small cell carcinoma of the lung, you get another characteristic feature that usually they have this nucleus, the chromatin pattern is finely granular. The chromatin pattern is finely granular. That means usually the chromatin patterns is like, this is also described as salt and pepper chromatin pattern. Means you can think in this way, that this is a fine drops of chromatin like sprinkled on a white, I would say, white plate in a restaurant where they have sprinkled a lot of salt and pepper. So they look like this. This is called salt and pepper chromatin pattern. Chromatin pattern. And this is the nucleus. So salt and pepper chromatin pattern you'd be seeing in higher magnification if you look closely at the nucleus, and also known as finely granular chromatin pattern. And nucleus in some places they could oppose to each other, the nucleus of the tumor cells, like this way. And they could, this is usually described by the term nuclear molding. It's something like this, that when the cells usually, you can think in this way, like you have seen in the Disney cartoon, that when a cartoon character is banging its head on the wall, it basically gets flat. It's something like this. And when the two tumor cells are clashing with each other, you can think in this way, they usually oppose to each other and they usually take each other's shape. This is the idea of the nuclear molding. And also another feature which is seen, that is called Ajopartis phenomenon, which is noted in the small cell carcinoma. I would like to explain it here. What is Ajopartis phenomena? One first concept that you need to understand here, that all small cell carcinoma, they usually undergo extensive necrosis. This is a characteristic feature of small cell carcinoma, and they also have high mitotic rate. Now, usually this is, suppose this is a cancer cell of small cell carcinoma, and it's entirely made with nucleus. And this cell undergo necrosis. What happens after the necrosis? If they undergo necrosis, necrosis means that the content of the cell should be leaked outside the cell, because that is the key differentiating feature with apoptosis. Apoptosis is it's not leaked. And this nucleus, the nuclear material in this cancer cell, it's mostly, the cell is mostly made with nucleus, not with cytoplasm, because the cell has very little cytoplasm and mostly it's made with nucleus. So when the cell undergo necrosis, the nuclear content, basically the DNA, they would be leaked out from the cells like this, and they would be deposited around a nearby blood vessel. This is the blood vessel. So these nuclear material, they would start depositing surrounding the nearby blood vessel. And now when we do a normal hematoxylin eosin stain, because normally we stain any biopsy, normal histologic biopsy by hematoxylin eosin stain. And hematoxylin usually stains the nucleus part. They usually have this bluish black appearance you see. That's why in a normal histology slide you have seen, the nucleus appears bluish black and the cytoplasm appears pinkish, because it is stained by, the cytoplasm is actually stained by eosin. That's why it's taking the eosin color. Now, all this nuclear material, because the cell is entirely made with nucleus, and the nuclear content, the DNA material, they are basically getting deposited surrounding the blood vessel. And when this is stained in the biopsy, we are getting a lot of basophilic bands, basophilic deposition surrounding the blood vessel, because they are basically those leaked DNA material which has been leaked out of the cancer cells. And this was first noted by a gentleman named as Dr. Azopardi, and this phenomenon is known as Ajopardi's phenomenon, which is also one of the diagnostic feature of this thing. So, what are the key points in the diagnostic feature of the small cell carcinoma? Let me write it here. Let me first clear this everything. What are the So you'd be getting neoplastic seeds of neoplastic tumor cells, which has scanned cytoplasm or sparse cytoplasm. Very high nucleocytoplasmic ratio, high NC ratio. Then you'll be having salt and pepper chromatin pattern. As I'm typing here, this pattern is also known, you can describe as finely granular chromatin pattern. And I mentioned then that they would look like that somebody has sprinkled on a white plate the salt and pepper. That's why they look like that. This appearance. That means chromatins just look like the chromatin appearance, the nucleus, they look like salt and pepper sprinkled over a white plate. Then you can get the feature of nuclear molding. Molding is spelled both as M-O-U-L-D-I-N-G, M-O-L-D-I-N-G, both are fine. Then you can also have extensive necrosis. And extensive necrosis would lead to Ajopardy's phenomenon, which I already explained, or Ajopardy effect, some people say. There will be high mitotic rate. And in electron microscopy, this is not seen in the light microscope, so you can see neurosecretory granules in EM. Why you see these neurosecretory granules? Because I told you that they are basically neuroendocrine origin tumor, and they are basically secreting a lot of hormones, as I mentioned, antidiuretic hormone and ACTH. And obviously, they are located in the sac of the cytoplasm from where this tumor cells release, and that's why the tumor cells so release this hormone. So you can see those that they are stored. These hormones are stored in the cytoplasm of this cancer cells, but you cannot appreciate them because they are so small. You cannot appreciate them in light microscope. You need to see those neurosecretory granules in the electron microscope because they can zoom in a better way there. And coming to the markers, and before the marker, immunohistochemical marker, I like to talk about tumor marker. Tumor marker usually you measure in the serum, the urine. And the serum of this patient, you can get high. Tumor marker is used for this is neuron specific enolage, NSE. Neuron specific enolage. And coming to the immunohistochemical marker, there are a lot of immunohistochemical markers are there, like CD56, also called NCAM, synaptophysin, chromogranin. Another one has come that's called insulinoma-associated protein 1. That is also used as a immunohistochemical marker for this condition. And if you're an advanced learner, you can learn about this, that these are the typical immunohistochemical markers. I mentioned about synaptophysin. So these are some immunohistochemical markers you can think, that is CD56, synaptophysin, chromogranin. These are the usual ISC marker. Immunohistochemical markers means that immunohistochemistry, the term is made with three things: immunology, for that immuno, histo means histology, and chemistry. Also, you are using the basic principles of the chemistry. So immunohistochemical markers are usually detected on slides, while the tumor markers usually detect on the, not on the slide, but usually detect on the serum or the urine. So this is the difference between the tumor marker and the immunohistochemical marker. And the last three things I am talking about is the immunohistochemical markers. And nowadays the newer ones has come, like I mentioned, insulin-associated protein 1. This is a newer marker which is very specific for neuroendocrine origin tumors in the lung. And also they could be positive for TTF1, thyroid transcription factor 1. Thyroid transcription factor 1, now they're originally seen in the thyroid, but now later they have seen they're positive in the lung also. So if TTF1 is positive, this is helps because neuroendocrine cancer could be of many origin, could be lungs origin from other places also. But if you get a neuroendocrine tumor of TTF1 positivity, it helps in some ways that they are lung origin. But as I mentioned, the TTF1 is not the best marker for the small cell carcinoma. The other good markers are NCAM, CD56, cyanotophysine, chromogranin, insulin associated protein 1, all this there has come. And lastly, the point is that, as I mentioned you, that prognosis of overall small cell carcinoma is very poor because it's widely metastatic at the prognosis. And one good thing about this bad tumor is that initially they're usually responsive to chemotherapy. But also, as the tumor usually present with a widespread metastasis at a higher stage, usually the prognosis is very poor. And overall, if you note the 5-year survival rate of the 5-year survival rate of the lung cancer usually is 16.8% or 7%. This way, it's for the latest study which they have seen. So that is also not good overall if you look at this, the cancer, the lung cancer. So in a nutshell, what we learned about the small cell carcinoma of the lung today, that small cell carcinoma of the lung is the most aggressive, deadliest, most lethal form of the lung cancer. And the problem with this cancer is too, it has a very rapid doubling time. It doubles in a very less span of time, so it can proliferate in a very rapidly. And secondly, it is widely metastatic at the time of presentation, and it can metastasize to many places like central nervous system, bone marrow, adrenal, liver, and all these places, and they can present with this presentation. When you think about the presentation of the small cell carcinoma, it's better to put it into 3 boxes, as I mentioned. First set of presentation would be due to the involvement of the lung or the thoracic region, the nearby means local invasion. Second set of presentation would be distant metastasis, like to central nervous system, liver, bone. And the third set of presentation would be paraneoplastic syndrome. Paraneoplastic syndrome, think about 3A, release of A. First A is for antidiuretic hormone, second A is for adrenocorticotropic hormone, ACTH, and the third A for a lot of antibodies. Particularly important one I mentioned is Lambert-Eaton myasthenic syndrome, which is basically a problem of presynaptic neuromuscular junction, where they cannot release the acetylcholine from the neuromuscular junction. So usually they present with the proximal muscle weakness. And often the Lambert-Eaton myasthenic syndrome could present even before the small cell carcinoma of the lung is present in the patient. Then I mentioned that is strongly associated with smoking. And at this point, you also need to keep few characteristic feature of their pathogenesis. They're usually associated with P53 mutation. They're also associated with the retinoblastoma. So this actually the suppression of these tumor suppression genes, that means P53 and RB, that is important in their pathogenesis, because if you know that tumor suppressor gene basically prevents the cancer development. So if the tumor suppressor gene is suppressed, that is minus, there will be plus, that means that will help in the cancer development. So these things usually plays a crucial role in the pathogenesis of this thing. Even the MYC gene amplification is also associated with some cases of the small cell carcinoma. And there are other things also there play a crucial role in the small cell carcinoma, but I mentioned only about the key ones. Then the next important point you need to know about their diagnosis, because ultimately they will be diagnosed by the biopsy. Usually they are centrally located, and that's why they usually present with the cuff. And usually in the biopsy you get that hyperchromatic bluish cells where the cells are small because they are less than 3 times the diameter of a resting lymphocyte. The cells have a very high nucleocytoplasmic ratio because the cell is mostly made of nucleus and a little bit of cytoplasm. The cytoplasm usually can have neurosecretory granules which can appreciate only in the electron microscopy. The nucleus usually have a particular chromatin pattern. This is known as salt and pepper chromatin pattern or finely granular chromatin pattern. They can have features of nuclear molding. They can have extensive necrosis, and they can have high mitotic rate. These are the usual features in the biopsy which you see. And they can have Agiopardis phenomenon. Agiopardis phenomenon, I mentioned that usually the tumor cells are leaking the nuclear material, and the nuclear material getting deposited surrounding the blood vessel. And this basophilic crust of the nuclear materials can be stained, and when they are stained, they present as some concentric bands surrounding the blood vessel. This is known as Agiopardis phenomenon, as it was first noted by Dr. Agiopardi. The tumor marker is definitely the tumor marker I mentioned for this is neuron-specific annullage, and there are certain immunohistochemical markers are also there for this neuroendocrine tumor, that is CD56, neuron synaptophysin, chromogranin. A newer one has come like insulin-associated protein 1. So there are many other markers have been invented, which is helps in precise diagnosis of the small cell carcinoma. And overall, small cell carcinoma carries a poor prognosis due to its rapid metastasis, and it's usually inoperable due to the at the time of the diagnosis. And that's why usually we divide the generally for a management purpose the cancers between small cell carcinoma and non-small cell carcinoma. And because small cell carcinoma is it's unique, it's distinctive in its nature, its biological property due to its high rapid doubling rate and its rapid metastasis. So as it metastasizes to distant space at the time of diagnosis, it has already spread to many places. Maybe it has spread to the liver, it has spread to the brain, it has spread to the lung. Now you cannot remove everything from the patient's body, his brain, his lung, his liver, his adrenal or his bone, because nothing would remain in the patient. So obviously it need to be treated by chemotherapy or radiation. That's why. And while the other tumors mostly, you can do surgical resection. That is the basic idea of this thing. So that was the idea. There's a general key concept that you need to learn about the small cell carcinoma. And thank you very much for attending this session. We'll continue the discussion on the lung cancers in the coming InstaLecture session. Thank you very much.